let's look at some of the things that would worry me as a psychiatrist, but would probably appear very normal to people. And we can look at the first one with medication, psychiatric medication. And here we can look at two common categories, so antidepressants, particularly SSRIs, and antipsychotics. So a patient comes in with distressing symptoms of, let's say, depression or anxiety, and they feel out of control, they feel very unstable, and the diagnosis is made that this person, let's say, has major depressive disorder, or this patient has illness anxiety disorder, and they're prescribed the SSRIs, and they're told this will take about 4 weeks to work. And let's say they wait until the 4 weeks and they start feeling good. So their distressing symptoms are alleviated. They no longer feel irritable. Their appetite is back. They're able to sleep at night. So life is restored. But they add this thing. They say, things don't get to me anymore the way they used to. And you listen to them and they tell you how, people could do the things that used to get them to overreact, but now they have no reaction at all. Now they don't feel anything at all. That concerns me, but it doesn't concern the patient because that is the desired goal. I know a lot of patients, when they feel emotions intensely, they tend to desire to never feel emotions at all. And so when somebody's telling me I don't feel anything at all, I try to assess, might there be emotional numbness, and might this be a side effect of the antidepressant, not necessarily the targeted effect. So those are my concerns, yes. But you can see for the patient, and even maybe for the relatives, the family of the patient, they might feel very relieved that now they can talk to the patient. The patient is not as irritable, is not on edge as they used to. The other one is the antipsychotic. So a patient comes in with acute symptoms of psychosis. They are agitated, they're aggressive, they're breaking things, they're destroying things, and people are finding it very difficult to stop them. And so maybe they might restrain them and take them to a hospital. When they get there, the first thing to do is to stabilize the patient, to bring down the psychotic episode. And this could be done by injection. Usually it is, because it's very difficult to communicate to the patient and to get them to take a tablet. And so they're given the injection and then it knocks them out. And then they're knocked out for, let's say, 2 days straight, or even 3 days. For the relatives, they might find relief in this, that the person who was bothering us, is now calm and stable. But then this person is just sleeping the whole time. They wake up to eat, you wake them up to eat, and it's very difficult to wake them up. So for me, it worries me, because I start wondering, was the dosage maybe too much? The way that this person the way the body distributes the medication and absorbs it, is there an issue there? So these are the things that would concern me, because you want to be able to stabilize the psychosis without rendering the person completely dysfunctional, without, making the person sort of appear like a zombie, yeah? But for the family, like I said, and even for maybe the people attending to this particular patient, that would be a relief that he's out for, as long as he's out, because now he's not bothering us. The other thing that worries me would be, let's say a person has neuroticism as a personality, and this is their normal personality. Neuroticism means this person worries constantly about several things or everything, and that's their normal. They've been doing that for 50 years, they've been doing that for 60 years. That's neuroticism. When they're interacting with people who are meeting them for the first time, that person might think, oh, this person has got anxiety disorder. No, that's just how they are. That's just how they're built. They worry about things. And so their baseline emotion is a little bit higher to, let's say, the other personalities, like conscientious, extroverted, open-minded people. And these people with neuroticism are also susceptible to mental illnesses, specifically anxiety disorders. So people with people who rank high in neuroticism are likely to get generalized anxiety disorder, social phobia, panic disorder. They're likely to get OCD or different kinds of OCD disorders. They're likely to get hypochondriasis. Now we call it illness anxiety disorder or somatic symptom disorder. So they're likely to get all these different types of illnesses. Now let's say this person has lived for 25 years without any anxiety disorder, but they've been neurotic. And they know that they worry a lot more than other people. And so they develop an anxiety disorder, maybe they even get a panic disorder, and they get treated for it. And they respond well to the treatment. And then something tragic happens to them. You expect that their neurotic personality is going to come in, and they're going to worry about what is happening, how they're going to handle it. Let's say the tragic thing is that they got into an accident and they don't know if they broke their leg or not, but they're feeling a lot of pain there. You expect that, I would expect that they're going to be really worried, in fact more worried than, someone with extroversion as a personality. But then this person, initially they're worried, but then when they put on a painkiller, a strong painkiller, because this is intense pain, let's say an opioid, they put on the opioid, the pain goes away, the physical pain, as she awaits or he awaits investigation to find out what is wrong and how bad it is. But then after the opioid injection, the pain goes away. But with opioid, there's also this side effect of a high. And so after getting that painkiller, this person does not exhibit any intense worry about their situation. They're not worried about what is wrong with their leg. They're not worried what would it mean in their life. They're not having this reaction. And for a lot of people, when they look at that, they might think, oh, she's managing it really well, or he is managing it really well. But for me, I'm a bit worried, because if they're finding a lot of assurance and a lot of comfort in the high, in the euphoria of the opioid, then that starts making me wonder if they're more likely to develop dependence on that opioid. Dependence here is addiction. They're more likely to start depending on the opioid to do life or to deal with life. So those are the things that would normally worry me as a psychiatrist, that other people might look at and think they're just normal.